Hello everyone, my name is David Eisen. Greetings from Toronto. I'd like to thank Purell Pharma for sponsoring this talk. Purell is a company that supplies dentists internationally with local anesthetics, and more recently they supply dentists in North America with Articaine, which I'll talk about later on in this lecture. I'm a dentist. I practice in Toronto, and I have an anesthesia-based dental practice. Most of my patients are people who need special care in the dental office. For example, people who are hard to get numb, which I guess is in part why I'm presenting this talk. This talk is an excerpt from a full-day local anesthetic course that I present, and I've got a lot of information packed in, and so there'll be a 50-minute presentation, and then if there are any questions, that you know how to type them to me, and I'll repeat the question and then answer it accordingly. Unfortunately, there's not enough time for me to answer questions as we go. Too many people logged on and lots of information to go through. So without any further ado, I will begin the presentation, and thank you all for spending the next hour or so with me. Now, I always like to start when I talk about local anesthetics by using an analogy of a light switch. As a practicing dentist using a local anesthetic for our patients, we're very lucky because local anesthetics in general are very good. They're very reliable and very safe, and it's very rare for us to have an issue or a failed block, for example. But that does happen, and similar to turning on a light, we don't really think about a light switch or wiring or a fixture when we walk into a room because we're pretty sure that the light is going to go on. But it's not until when the light doesn't go on that we have to start thinking about what the problem is. Problem solving, thinking about maybe the wiring or the bulb or the fixture or whatever the issue is. And with local anesthetics, it's similar. When we inject our patients and begin the operation and the patient is feeling pain, we have to start problem solving and trying to figure out what the issue is. Why didn't the local anesthetic work? So I'm going to talk today over the next 15 minutes or so about reasons that our local anesthetics fail us and suggest some ways to make local anesthesia in our practices more reliable. This list are the things that I could come up with that talk about reasons why local anesthetics fail, most often in the mandible. I think we all agree that anesthetizing the maxilla is a little bit easier. Most often areas of infection and the mandible are the tricky things that we encounter when we have to get someone numb. So I'll go through this list one at a time. We'll expand on each issue and look at ways to remedy the problem. First of all, if you're using the inferior alveolar nerve block as your method to block the mandible, or at least half the mandible, we should always keep in mind that this technique only has an 80% success rate of anesthetizing the full distribution of the inferior alveolar nerve. That means 20% of the time, somewhere along the distribution of that nerve, we won't have anesthesia. And if we're operating in that area, the patient's going to feel discomfort. Now, we don't always run into that spot that's not numb. Sometimes we're operating in another location, and so we don't notice it 20% of the time. But it really, an inferior alveolar nerve block isn't a reliable way to anesthetize the inferior alveolar nerve and its branches, and I'll talk about the reasons for that as we go further in the slides. We also know that if somebody has a hot tooth, if somebody's in pain when they come to us, they need an endodontic procedure or an extraction, and there's infection in the area, the ability to get them numb is even more difficult. In fact, even for an inferior alveolar nerve block or any block, it's less reliable if the tooth has a pulpitis. The reason for that is because the mediators of inflammation, things like histamines and kinines, something called substance P, these these substances can actually travel up the nerve tract along the inferior alveolar nerve and change the way the whole nerve reacts to the local anesthetic. So even though we're blocking the patient far away from where the area of infection and inflammation is, the local anesthetic still may not be effective even if we're giving a block. Sometimes when patients are referred to my clinic for restorative procedures, the first thing I'll do is I'll take a periapical radiograph. And frequently we'll find that the tooth that needed a restorative procedure actually needed an endodontic procedure. And the dentists send the patient to our clinic. They weren't able to get the person numb. Well, the reason they couldn't get them numb is because the person didn't need a restorative procedure. They actually needed an endodontic procedure. So it may be a clue if you're operating in the mandible or even in the maxilla and you give somebody an infiltration and you don't get good anesthesia, or you give them a block and you don't get good anesthesia, take a periapical radiograph of the tooth and make sure that the patient does not need a root canal procedure, and maybe that's the reason why the local anesthetic is ineffective. Also, people who have been up for 2 or 3 days because of these very painful situations of having these very hot teeth, we all know when they come to our office, they're really not ready to accept the local anesthetic in a normal fashion. Emotionally, they can't deal with the stress of the dental procedure as well as they could if they were rested and pain-free. And so they'll react to stimuli differently than they would if they weren't under such stress. And so even the vibration of the handpiece or pushing on their tooth, that can be interpreted as pain because of their very heightened emotional state. A study was done by a group to look at whether NSAIDs, non-steroidal anti-inflammatory drugs, would help local anesthetics work in areas of infection. This study looked at patients with pulpitis in mandibular molars, and they divided the group into 3. Group 1 received 75 milligrams of indomethacin, which is a non-steroidal anti-inflammatory drug. Group 2 received 600 milligrams of ibuprofen, another NSAID, and the third group received a placebo pill. Each of these groups received their drug or placebo 1 hour before treatment, and then they were all given an inferior alveolar nerve block with 1.7 mils of lidocaine, 1 in 100,000. So the test here was, can the NSAIDs increase the success of local anesthetic compared to the placebo? And actually, this is what they saw. Both the ibuprofen group and the indomethacin group had a higher success of local anesthesia compared to the placebo group. So theoretically, or assuming here, that the NSAID was able to reduce the inflammation and infection even 1 hour before and allow the local anesthetic to work better. This is maybe a good idea for us to use on our patients. So if we're doing a procedure on a hot tooth or an area of inflammation, maybe it's a good idea to put the patient on a regimen of NSAIDs 48 hours or 24 hours before they receive the local anesthetic injection. Reducing the infection and inflammation in the area will help the local anesthetic be more effective. This study looked at the ability of articaine versus lidocaine to help people get numb, once again, in mandibular molars where there was an irreversible pulpitis. So in this case, one group received articaine, a block of articaine. Actually, it was 2 cartridges of articaine. And the second group received 2 cartridges of lidocaine. Would one of these local anesthetics be better than the other? Now, if you look at the numbers, you can see that articaine had a success rate of 65%, lidocaine was only 45%, so articaine was better, but this study had a very small sample size, and so the numbers were not statistically significant. Now, this might be a reason to use articaine in this type of a situation, or it might not. But, if we want to try and do everything we possibly can to get our patients numb in areas of pulpitis, this study may suggest articaine might have a slightly higher efficacy than lidocaine. What else can we do to help our patients when they have pulpitis and these hard to numb teeth? Well, one thing is to use nitrous oxide. So this study looked at using nitrous oxide as an adjunct to effective local anesthesia. They tested patients once again with irreversible pulpitis. One group received only oxygen and local anesthetic, and the second group received a mean dose of 43% nitrous oxide plus the local anesthetic. The results showed that the patients who had the nitrous oxide had a higher success of the inferior alveolar nerve block than the group that only had the oxygen. Now, I don't know if the nitrous oxide was more of dissociative. It certainly does have some analgesic properties to it, so that may be what helped the patients get numb in this situation. So nitrous oxide might be a good way, again, like an NSAID, to help our patients be more comfortable during these difficult to anesthetize situations. The second reason we sometimes have a hard time numbing our patients might be the length of needle we're using. If you see this image, there are 3 lengths of needle that we have available to us. The top 2 are so-called long needles, which are 35 millimeters long. The syringe that's second from the bottom, right here, this is a 25 millimeter needle, and the syringe on the bottom is an ultra short needle, which is about 10 millimeters long. Now, if you're doing an inferior alveolar nerve block on an adult, the average depth that we have to go is 25 millimeters. So, if we're using this syringe here, this short needle, which again is 25 millimeters long, we have to inject to the hub every time for the average size adult in order to get close to where the inferior alveolar nerve is. Using longer needles, the 2 on top, affords us the ability to look at how much needle is sticking outside of the tissue when we're at our final depth. So, for an average depth of 25 millimeters, we'll see 10 millimeters of needle sticking outside of the tissue when we're at the depth we need to be. Also, the longer needles afford us the ability to go deeper without the danger of injecting to the hub. It does happen where the needle can separate from the hub. The typical scenario is injecting to the hub, hitting bone, sometimes aggressively by mistake, the patient feeling a significant amount of pain, jerking their head to the side, and that movement and the pain can separate the needle from the hub. If we've injected all the way to the hub, then it's going to be virtually impossible to retrieve the needle. So longer needles decrease the chance of that happening. Also, longer needles have a higher gauge. They are either 25 gauge on top or 27 gauge on the bottom. Well, why does that matter? The 25 gauge needles, the thicker ones, tend to deflect less when they go into tissue. So if you look at this red rectangle, which is, let's say, a block of tissue, as this needle travels through tissue, it will deflect away from the bevel. Here's the bevel. The forces, the density of the tissue, will cause the needle to deflect away from the straight line. The flimsier the needle is, the more this will occur. So if you take a 30 gauge needle, which is the thinnest needle that we would have available to us, and you inject it to a depth of 25 millimeters, you'll get 4 millimeters of deflection away from the straight line. And that 4 millimeters could make our block less accurate. If we use a 27 gauge needle, you'll only get about 2 millimeters of deflection at a depth of 25 millimeters. And if you use a 25 gauge needle, the thickest needle, you only get about a 1 millimeter of deflection. Keep in mind that larger gauge needles, thicker needles, don't hurt more. Studies have shown that patients can't tell the difference from the pain elicited from the pinch of a 25, 27, or 30 gauge needle. They can't feel the difference. What they can feel is that the 25 gauge needle, having a wider lumen, will allow the local anesthetic to come out more freely. It takes less resistance for us to push the solution into the tissue if the core of the needle is bigger. So that could hurt more. It's the expansion of the tissues that actually causes the most amount of pain, not the gauge of the needle. Also, the advantage of having a 25 gauge needle, not only do we have a more stable or straight-on injection, but we have the best ability to reliably aspirate if we should be in a vein by mistake. Sometimes, especially 30 gauge needles, they can be right in the middle of a vein, and the lumen is too narrow to suck blood back into the local anesthetic cartridge when you depress your aspirating ring or pull back on the local anesthetic syringe also. So 25 gauge needles are the best reliable aspirators that we have. Another thing that we can do to make our blocks more accurate, not only hurt less, is to inject more slowly. Slow inferior alveolar nerve blocks have a higher success rate than fast inferior alveolar nerve blocks. This study compared a block given over 60 seconds compared to a block given over 15 seconds. And you can see the number of teeth that were successfully anesthetized, molars, premolars, and lateral incisors, had a higher success rate of anesthesia with the slow block compared to the fast block. So there's two good things here. It hurts less because we're injecting slowly, and we have a more reliable injection. With the slow injection, more of the local anesthetic molecules will be at the tip of the needle, which should be very close to the nerve. And compared to the fast block, where the local anesthetic will spread more throughout the tissues because of the force of our injection. Now, what about the volume of local anesthetic and its ability to give us good anesthesia? Do we need more molecules of local anesthetic in some patients? More molecules meaning more volume. We have these cartridges, and depending on where you are in the world, and I see from the people registered that we have people from all over the world, some of you have 1 mil cartridges, some of you have 1.8 mil cartridges, some of you have 2.2 mil cartridges. So we have a big variation of volume. And why do we have those amounts? It's very random. Sometimes one cartridge is enough, sometimes it isn't. Many of us, for our patients who are hard to anesthetize, will instinctively give 2 cartridges right off the bat, simply to give more volume in the area that we want to have a local anesthetic. But let's take a look at a few factors. So this is a schematic cross-section of a nerve, and the image on top shows maybe what happens after 1 minute after giving our inferior alveolar nerve block. You can see this dark representation here around the outside of this nerve. This would be the solution of local anesthetic, which is beginning to completely encapsulate the, let's say, inferior alveolar nerve. These little black dots might be molecules of local anesthetic that have begun to infiltrate into the core nerve. But you can see here that we have a large area of the core nerve that has not yet been bathed with local anesthetic molecules, and so of course at this point we won't have a full block. So there will be areas of the mandible that are not yet anesthetized. We just simply haven't waited long enough for this to occur on the bottom, where the local anesthetic has completely encapsulated the nerve and many molecules have had the time to infiltrate in and do what they need to do. We'll talk in a few minutes about certain factors that can help this to happen more quickly. Another interesting thing to think about is the location of our injection will change how long it takes for the block to occur. In general, the higher we give a block in the mandible, the longer it will take for the block to sock in, because the nerve is thicker the higher we go. So this would be a dissection of the pterygomandibular triangle. This is the right side. So the patient's right ear would be here. This is the condyle, the medial aspect of the right condyle. And this is the mandibular nerve, which comes down through foramen ovale, gives off the long buccal nerve here. Comes down further, you have the lingual nerve and the inferior alveolar nerve, which enters the mandible at this location. This is where we give our inferior alveolar nerve block, and the nerve, as you can see, is somewhat thin, as opposed to the location of a higher block, for example a Gauguet's block, where the nerve is much thicker, and obviously with a thicker nerve, it's going to take a longer time for this nerve to become anesthetized. So the higher we go, the longer we have to wait. Also, there are some barriers to the spread of local anesthetic to the inferior alveolar nerve. One of the barriers is called the sphenomandibular ligament. This ligament goes from the sphenoid process to the lingula area on the medial aspect of the ramus, and associated with this ligament is a fascia of tissue that acts as almost a curtain. And if we inject our local anesthetic on the medial aspect of this barrier, it may not be able to swim laterally to the bone and the nerve. This might be a situation where we give our block and the patient has no signs of anesthesia at all. No lip anesthesia, no tongue anesthesia, of course no heart tissue anesthesia either. We've injected too medially and the anesthetic can't swim laterally to get to the nerve. This is one reason why if the needle tip touches bone, it helps to tell us that we've gone through this barrier. Now, of course, if it touches bone, patients do feel that the periosteum is innervated, and that's could be a painful thing for us to do for our patients. We want to try and avoid that as much as possible, but touching bone does tell us we've gone through this barrier and we won't be injecting too medially. The other barrier, obviously, is giving an intravascular injection. If we inadvertently put our needle tip into a vein and we don't aspirate, or we're using a 30-gauge needle and we inject the full cartridge into a vessel, well, obviously we're not going to get any anesthesia at all. Veins have very thin, smooth muscle walls. The patient won't feel that penetration. The first recognition that they'll tell us about usually is palpitations from the vasoconstrictor of the local anesthetic, stimulating the cardiovascular system. Injecting into an artery is pretty tough. Arteries have thicker, smooth muscle walls which are well innervated, and the patient feels an extreme amount of pain when the needle tip touches an artery. The side of their face turns white. They feel deep pain in their head and their face, and usually they'll pull their head backwards and won't allow us to inject into that artery. But without aspirating, an intravascular injection is very possible. Another reason for not getting good anesthesia in the mandible is some tricky anatomy in the mandible. So when we give an inferior alveolar nerve block, the first thing our finger should feel for is this depression on the anterior border of the ramus called the external oblique ridge. After our finger feels the external oblique ridge, we then fall into the internal oblique ridge, and that's where our finger will sit and guide the needle past and get to the lingula where the nerve enters the bone. The reason we're feeling for this greatest depression on the anterior border of the ramus is because it tells us approximately where the inferior alveolar nerve enters bone. So that's why we're looking for that depression. Now, the internal oblique ridge, the distance from the external to the internal oblique ridge varies from patient to patient. In patient A, you can see it's very narrow. In patient D, C, and D, you can see it's very wide. And if we feel this very wide plate of bone, it's really important for us to have our finger on this ridge, on this internal oblique ridge, to guide the needle past. This is the situation where if our finger isn't here, we hit bone after 1 or 2 millimeters. Instinctively, we know we have to pull back, maybe angle the barrel of our syringe more distally on the contralateral side in order to get that straight line approach to where the inferior alveolar nerve enters the ramus. It's pretty tricky when you have this wide plate of bone and a very widely flaring mandible. It's a hard thing to do. The more the mandible flares, the more difficult that situation will be. The other variable is that the inferior alveolar nerve can enter the ramus at different locations. It could be 19 millimeters above the occlusal plane or 1 or 2 millimeters above the occlusal plane. And if we give our block down here in the lower aspect of the ramus and the inferior alveolar nerve enters bone up here, well, we're not going to get good anesthesia because the nerve has tucked into bone superior to the location of our injection. This might be one reason why higher blocks tend to be more successful. It discounts this variable. Another reason why higher blocks are more successful is because about 60% of the adult population will have accessory innervation to the mandibular teeth from the mylohyoid nerve. The mylohyoid nerve leaves the inferior alveolar nerve about 15 millimeters above the location for our inferior alveolar nerve block. So if we give our injection down here and the mylohyoid nerve leaves up here, we won't get good anesthesia if that mylohyoid nerve gives accessory innervation to the mandibular teeth. Blanton wrote a great article about the anatomy of local anesthesia, and one of the things she highlights is that accessory nerves can leave different nerves, different branches of V3, and re-enter the mandible through foramen that exist on the lingual side of teeth, of the dentition. Now, if you're working on a lower 7, let's say, a lower second molar, and there happens to be one of these foramen adjacent to this second molar, and accessory innervation comes from the mylohyoid nerve or the long buccal nerve or the inferior alveolar nerve, and re-enters the mandible and goes into this foramen and innervates the second molar, you may have a hot spot in the second molar even if the patient says their lip is numb and their tongue is numb. It may be that accessory innervation is innervating a specific tooth. So we have this issue of the mylohyoid nerve innervating our mandibular teeth. Well, one of the things we can do to anesthetize these accessory nerves is give an injection on the lingual side of the tooth that we're working on. If we drop in about half a mil of local anesthetic on the vertical aspect of the alveolar ridge, not in the floor of the mouth because that's where the submandibular salivary glands are, so we want to be on the vertical aspect of the alveolar ridge, we will get anesthesia of the accessory nerve, if it's there, which enters that area on the tooth that we're working on. So again, on the vertical aspect of the alveolar ridge, not in the floor of the mouth, about half a cc of local anesthetic. And it's a little bit easier for one to administer this injection on the unattached gingiva, because the unattached gingiva will better accept the volume of local anesthetic. Of course, you will see a little ballooning of the tissue, which will go away. And the patient won't feel this because usually we've given a block already, and so the soft tissue is numb. So because the block has already been given, it's a painless injection and quite effective one as well to anesthetize those accessory nerves. The other reason for a failed block is the degradation of the local anesthetic molecule. Now, normally we get about 18 months to 2 years of shelf life with our local anesthetics. Actually, the company PRL, who's sponsoring this talk, they make an articaine local anesthetic in North America that actually has a longer shelf life than our other local anesthetics. It is a 24-month shelf life as opposed to an 18-month shelf life. So obviously, longer shelf lives afford a little bit more stability towards the end of the life of the local anesthetic. Now, if you leave your cartridge on a desk and expose it to light, after 2 weeks, you'll lose 75% of the active molecules. So we want to make sure we're storing our local anesthetics in the dark and allowing our local anesthetics to reach their stale date and not letting those local anesthetic molecules degrade. Of course, if we have degradation of the product in the cartridge, we will have less effective local anesthetic. I think you'll all agree with me that many times the people who are hardest to get numb are the ones who cooperate the least. So here you can see on the top the typical position of a patient who's scared. And we ask these people to open their mouth and they can barely do so. And if they can't open their mouth, if they don't lift their chin away from their chest, if they can't do this for us, well, it's very difficult for us to get into their mouths with our finger, landmark the areas that we need to landmark, and put the needle and syringe in there as well. They have to take their chin up off their chest, open wide, and stay open wide throughout the course of the injection so that we can effectively landmark properly and put the local anesthetic where we want to put it. So how do you convince your patient to do this? And we have to coach them that the more they help us, especially the very scared people who are hard to get numb, the more they help us, the better we'll be able to do what we need to do and get them numb properly. Depending on where you are, there are different methods of anxiolysis that you can use. Oral anxiolytics, drugs, benzodiazepine type drugs, or laughing gas, or even just being gentle and nice can really go a long way for these people and help them to cooperate so that we can get in there and do what we have to do. Now, sometimes the reason the local anesthetic fails is because of the local anesthetic itself. So let's take a look at the local anesthetic molecule and understand how sometimes the molecule of the anesthetic and an acidic environment, like infection or inflammation, can stop the local anesthetic molecule from going through the nerve. So here is a schematic picture of a local anesthetic molecule. 3 parts, an aromatic ring, which is always a benzene ring unless we're talking about articaine, which is a toluene ring, and we have the terminal amine portion. The middle portion differentiates different local anesthetics from one to the other. All of our injectables, at least in North America and most other places in the world, are amide-based local anesthetics. So the terminal amine portion can carry a positive charge, making this an ionic molecule, and with a positive charge, this molecule will go into the sodium channel and block the action potential from occurring. But before that happens, the local anesthetic has to be neutral. And neutral, the local anesthetic molecule in the neutral state, is the type of molecule that goes through the nerve membrane. So you need that neutral molecule first to go through the nerve and then block the action potential later with the positive charged version of the molecule. So here's a schematic representation. We're going to inject a local anesthetic B into the tissue, sets up an equilibrium, and we get a neutral local anesthetic molecule and a charged local anesthetic molecule. Neutral molecule goes through the nerve membrane, it re-equilibrates in the new environment, we get the ionic molecule blocking the action potential from occurring. The interesting thing about the local anesthetic equilibrium here is that the B molecule, the neutral molecule, is 4,000 times more lipid soluble than the charged molecule. So when we inject this stuff, we want as many neutral molecules as possible and as few charged molecules as possible in order to make the local anesthetic work quickly and efficiently. Well, how can we affect this equilibrium? There are two things to think about, two factors. One we can't control and one we can. The first factor which we cannot control is something called pKa. pKa is defined as the pH at which half of the molecules are neutral and half of the molecules are charged. So, if we were to have a local anesthetic with a pKa of 7.4, it doesn't exist, but let's say fictitiously if we did, and if we injected that local anesthetic into neutral tissue pH, which is also 7.4, we would have 50% of our molecules lipid soluble and another 50% water soluble. So here we would have a pretty good proportion of our local anesthetic molecules which would be able to go through the nerve. Now, unfortunately, our local anesthetics all have higher pKa's than 7.4. And right away, that shifts the equilibrium away from the neutral molecule. So we always have fewer neutral molecules than charged molecules. But this is just the nature of what we have, and it's as good as we get. If you go all the way down to bupivacaine, for example, brand names are Marcaine or Vivacaine, there's some other ones as well, Sensorcaine, you can see that bupivacaine with a very high pKa only has 18% of its molecules available for lipid solubility. Bupivacaine takes longer to work in part because of that. Now, the factor that we can affect is something called pH. But first, let's take a look at articaine, which has a pKa of 7.8. If we inject articaine, pKa of 7.8, into neutral tissue, pH 7.4, we have only 29% of our molecules lipid soluble. Again, this is the best result we can get, and there's nothing we can do to change the pKa. Let's see how infection shifts this equilibrium. I think it'll be no surprise that infection shifts the equilibrium towards the charged molecule. This is why when we inject in an area of infection, for example, a hot tooth or a tooth with severe periodontal disease, a local anesthetic that's acidic won't have a good chance of working. The acidity influences the charged molecule more than the lipid-soluble molecule, and so you don't have enough lipid-soluble molecules to get through the nerve. I can illustrate this mathematically, but because of time, I'm just going to skip through this very quickly. But if you see that in the best case scenario with lidocaine, you get 3 bad particles, that is, charged particles, for every lipid-soluble particle that's available. And again, this is as good as it gets. If we give a block and we get this situation and we don't have good anesthesia, let's say we take a second cartridge of articaine and give a second, or lidocaine or whatever, and give a second inferior nerve block. Well, now, because our local anesthetics with vasoconstrictor are acidic, we're injecting more acid into the area. So we're basically reducing the pH in the location of our injection, and we're decreasing the likelihood that the lipid-soluble molecule is going to exist. The more acidic local anesthetic we inject into the same area, the worse the situation is going to get. And after 1 or 2 cartridges, if we don't have good anesthesia, we should get away from our acidic solutions and use more basic solutions, which are solutions without a vasoconstrictor. Plain solutions do not have vasoconstrictor, nor do they have a preservative called sodium metabisulfite. That preservative must be present in local anesthetics with a vasoconstrictor, and that's what causes the local anesthetic cartridges to be acidic. The more vasoconstricted there is, the more acidic the cartridge will be, the less likelihood we have of getting good anesthesia after 2 or 3 cartridges of local anesthetic. So try and err towards the more basic solutions after your first injection. Now, what are the differences between the local anesthetics that we have available to us? Lidocaine, articaine, prilocaine, mepivacaine. What's the difference between all of these? And why would we choose one over the other? Duration is one factor. Of course, some local anesthetics like bupivacaine, have a longer duration of action. What about concentration? Do we want to choose a 2, 3, or 4% solution, one over the other in certain situations? Of course, we're going to think about plain solutions in our patients with cardiovascular disease if we can. But of course, with our cardiovascular disease patients, the most important thing to do is to minimize their pain, because their body will release more endogenous epinephrine than we could ever give them in a cartridge of local anesthetic. So if you choose a plain solution, make sure it gives you the duration of anesthesia that you require. Are we going to choose one local anesthetic over the other because it gives us better anesthesia, or just because this is what's in my office and this is what we have available? Or are we going to think about price? And we should look at price, because certain local anesthetics are less expensive and certain local anesthetics are more expensive, and you may not be getting less efficacy of anesthesia for less expensive local anesthetics. These are the 5 local anesthetics that are available in most places around the world, certainly in North America. Lidocaine, mepivacaine, prilocaine, articaine, and bupivacaine. Now, lidocaine and articaine are both very potent vasodilators. So in dentistry, in most places in the world, they must have a vasoconstrictor. As a plain solution, they would vasodilate the tissues where they're injected, be sucked up into the cardiovascular system, and give virtually no duration of anesthesia. Mepivacaine and prilocaine do not vasodilate as potently as lidocaine and articaine, and so they do have some efficacy as a plain solution. With mepivacaine, to make it efficacious as a plain solution, you have to put more local anesthetic in the cartridge. So plain mepivacaine comes as 3%, mepivacaine with a vasoconstrictor comes as 2%. Let's talk about articaine. Articaine is a completely different local anesthetics, and most of you listening have this available in your country. Now, articaine is different for these reasons. First of all, it's not metabolized in the liver the way our other local anesthetics are. Articaine is metabolized mostly in the blood by an enzyme called plasma esterase. Now, if somebody has something called a pseudocholinesterase deficiency, they're missing this enzyme, we can still safely give patients articaine because the liver will take over the metabolus of the drug. Articaine has a faster half-life. It's broken down more quickly in the body compared to our other local anesthetics, which have about an 1.5 to 2 hour half-life. Back to the plasma esterase breakdown of this drug, this is why articaine is good for patients with liver disease. If they have any liver problems, alcoholic liver disease or hepatitis, and we're worried about their liver function, articaine can be metabolized safely in these individuals. Now, articaine also in the molecule has an extra ester link, and theoretically this may make it better at crossing the barriers in the nerve. This is theoretical. Let's take a look at a few studies about articaine and think about a few things. This study compared articaine with lidocaine, and I'm going to build a case here for using articaine in the mandible as an infiltration drug, not as a blocking drug, but an infiltration drug. So articaine versus lidocaine infiltrating in the mandible, infiltrating beside a second molar, first molar, second premolar, first premolar. Successive anesthesia was pretty good. 75% for articaine in the second molar, 87% first molar, 92% second pre, and 86% first pre. Lidocaine, of course, didn't fare nearly as well. Now, you might agree with me that articaine as an infiltration drug in this study is almost as good as giving an inferior nerve block. So as an infiltration drug in the mandible, articaine is pretty effective. This study looked at patients receiving an inferior alveolar nerve block with articaine and then either an infiltration beside the first mandibular molar with articaine or lidocaine. The patients who had the articaine infiltration had a higher success of anesthesia compared to the patients who had a lidocaine infiltration. There are a number of different studies that show us today that articaine as an infiltration drug is relatively effective even for the mandibular first molar. It certainly is predictable for the second premolar, first premolar, and anterior teeth in the mandible as an infiltration drug. If we're using this beside a first molar, we might choose our patients carefully. We might decide to use articaine 1 in 100,000 epinephrine instead of 1 in 200,000 epinephrine because the higher vasoconstrictor concentration will keep the molecules at the site longer, theoretically giving us more molecules to penetrate the cortex. Choose smaller adults, females, people with thinner cortex. This might not work on a very large male. Supplement it with an inferior alveolar nerve block and also a lingual infiltration if you're really having a hard time getting these teeth numb. What about in the maxilla? Articaine versus lidocaine. Infiltrating beside a tooth with pulpitis. Articaine did better than lidocaine. So once again, in the maxilla, articaine does a better job than lidocaine does as an infiltration drug. Brandt did a meta-analysis in the literature in 2011 where he collated all of the studies with articaine compared to lidocaine as an infiltration drug. And he demonstrated that articaine was almost 4 times more likely to provide pulpal anesthesia via infiltration as compared to lidocaine. However, the literature doesn't really show us good evidence that articaine is better as a blocking agent. So for the inferior alveolar nerve block, we don't have great evidence that articaine is better than lidocaine. The other issue that we should think about is that as a 4% solution, there is the possibility, some studies have suggested that 4% solutions in Canada and the US, articaine is a 4% solution, there may be an issue with paresthesia, especially with the lingual nerve. So this is something that you should look at and research if you decide to use articaine as a blocking agent in the mandible. Now what about the inferior alveolar nerve block? Let's quickly review the advantages and disadvantages and then compare that to the Gaugates block and the Akinosi block very quickly. I'm going to go through this quite fast because this is stuff that you guys have all heard, but I just want to show you the advantages of the Gaugates block and the Akinosi block compared to the so-called inferior alveolar nerve block. So with this inferior alveolar nerve block, we're basically trying to inject the local anesthetic in this area here where the nerve enters bone. And this is something that we've all learned in dental school. We accept it, we're used to it, we're good at it, and we pretty much do it without even looking for landmarks usually. But it has some disadvantages. As I showed you, if the internal oblique ridge is thick, or if the nerve tucks into bone higher, we're not going to get good success. And of course, this will not anesthetize accessory nerves. So here you can see an example doing this block. Our finger or thumb falls into the mouth, and the first thing we feel is the external oblique ridge, the greatest notch on the anterior border of the ramus. And then we find the internal oblique ridge, which is here, and our finger or thumb will sit on the internal oblique ridge. The puncture point for our needle will be at the middle of our palpating finger between the internal oblique ridge and the pterygomandibular raphe. Looking like this. Here we go in. We're located over the contralateral second or first bicuspid on the average size mandible. And remember, the average depth is about 25 millimeters, and we can see 10 millimeters of needle sticking outside of the tissue if we're using a long needle. We will need to use a long buccal nerve injection in order to anesthetize the soft tissues beside the molars if we require soft tissue anesthesia in this situation. Now, if it doesn't work, we can use a closed mouth approach, and I'm just going to show you this as opposed to giving you the advantages and disadvantages. The closed mouth or Akinosi-Vazirani approach, where we're about 10 millimeters above the conventional block. So we're still going straight in, we're still parallel to the mandibular dentition, but we're about 10 millimeters higher. So we're going to do the exact same landmarking, external oblique ridge, internal oblique ridge, but we're going to slide our finger or thumb up 10 millimeters, and the mouth is going to be closed. So instead of injecting about here, we're injecting up here. And we're going to keep our finger on the coronoid process here to avoid the temporalis tendon. We want to make sure the needle doesn't touch this because that hurts. From a lateral aspect, our injection is at about the root apices of the maxillary teeth. So that's the height of the closed mouth Akinosi block. And it helps a lot if the patient can open slightly and excurd laterally. If they can give you this lateral excursion towards the side we're injecting, it opens up this so-called bony window, the bony window between the ramus and the maxillary process. So here we're going to landmark. This would be where we would be for the inferior nerve block. Here's where we are for the Akinosi nerve block. And as we do this clinically, you can see that it's pretty hard to see because now we have tissue in the way, and we actually have to reflect the maxillary lip in order to get a good vision of this injection. But our puncture point is going to be right about here at the tip of my cursor, at about the height of the mucogingival line in the maxilla, or again the root apices of the maxillary teeth. You can see the patient is open, it's skirting laterally, and in we go, and we get about the same depth as the inferior alveolar nerve block, and this would be, we wouldn't touch bone because we're going in parallel to the ramus. The Gauguet's block has a great advantage, and that is we're going to touch bone. Here's the Gauguet's block compared to the Akinosi and the conventional approach. In this case, not only is our puncture point higher, it's the same puncture point as the Akinosi block, but we have an angle to our injection, a trajectory which will get us to the upper corner of the ramus, well below the condyle. Inferior alveolar nerve block, Akinosi block, Gauguet's block. And this, for me, is the most reliable way to block the mandible because I know for sure I'm going to anesthetize the mylohyoid nerve and its branches. I'm going to anesthetize any other accessory nerve that would innervate the dentition, and I'm going to be above the location for where the inferior alveolar nerve enters bone. The only downside to this is, remember, we have to wait longer, 10 to 12 minutes for this whole block to sock in. So that's the downside to this approach. Here is where we would be depositing the local anesthetic. And we have to have our patient open wide. As they open wide, the condyle comes anteriorly to rest beside where the nerve is. Opening wide gives us a bony target beside the nerve. So we have our patient, they're going to lift their chin up, they're going to open as wide as they can, and they have to stay open wide. If they close while we're injecting, the condyle goes backwards, away from the nerve. So they have to stay open throughout the whole course of this injection so that we can find our target zone. The angle or the trajectory that I talked about is a line that goes from the corner of the mouth to the tragus of the ear. So when the needle and syringe is inside the patient's mouth and we're injecting, we want to make sure we're going along this plane. This plane, this line, will give us a direction in order to find the upper reaches of the ramus. And with the barrel of the syringe located on the contralateral side, exactly the same as with the standard block, we'll go in and in the average patient hit bone at about 25 millimeters. Sometimes a little more, sometimes a little less, depending on the class of the mandible. If they're class 3, we may hit bone more sooner, as opposed to the more retrognathic mandible where we might have to go a little deeper to find bone. And we're going to landmark this in the exact same way. External oblique ridge, internal oblique ridge, and here's our finger on the internal oblique ridge. Puncture point between the middle aspect of our finger, internal oblique ridge, and raphe. So we're simply adding a height of 10 millimeters to our puncture point, and we'll go in with our angle and try and find the upper reaches of the ramus. And this is what it would look like. We go in, touch bone gently, and pull back before we inject the full cartridge of local anesthetic. You don't want to inject onto the periosteum. Now, there are a lot of different descriptions online that you can find for both the Akinosi block and the Gaugates block in order to supplement what I've very quickly gone through. Finally, two final devices or ways to anesthetize the mandible when we have a really hard time. The first is intraosseous anesthesia, where we're making a hole in the cortex and injecting our local anesthetic into the cancellous space. There are two systems available, Stabident and X-Tip. They're both good. The advantage with the X-Tip system, this is by Tulsa Dental, is that you get a little guide sleeve that remains attached to the cortex, to the tissue, and you can inject through this guide. So it shows you where the hole is. So this is something that you might want to look into. It's a very reliable way to anesthetize a hot tooth, or in situations where it's hard to get the person numb. You need about a half of a cartridge of anesthetic. So while I'll tell you, with different size cartridges, you need about 1 cc of local anesthetic to get good anesthesia with this approach. The final approach is a PDL injection, where you can use these different devices to force the local anesthetic around the periodontal ligament and get anesthesia that way. And there are different devices that companies have available to us. This is called Paraject, this is called Cetoject, this is called the wand, as you know, you may have seen this around. And these are good ways to force the local anesthetic through the PDL space. But I've reserved this for situations where we're doing endo or extractions. This might not be the kindest approach for a vital tooth. There's a lot of pressure put on the PDL ligament when we do these injections. Finally, as a very quick summary before I open this up to questions, minimize your vasoconstrictor. Remember that more vasoconstrictor means more acid, which gives us fewer lipid-soluble molecules. Optimize your volume. Think about using more than one cartridge on people who are hard to get numb, and try longer needles in order to better gauge your depth if you think you are not able to do so with shorter needles. Remember that slower injections have a higher success rate if we're thinking about inferior alveolar nerve blocks. And don't forget to wait 4 minutes for that technique and 10 to 12 minutes if you inject higher in the pterygomandibular triangle location. Remember the lingual infiltration, the accessory nerves, especially from the mylohyoid nerve, entering the mandible through these foramen. Don't forget to landmark. If somebody's really hard to get numb, do every step one at a time. Find all those ridges of bone and make sure everything is lined up before you give the person their injection, making sure that they're helping you. Their mouth is open wide and they're staying open wide throughout the course of their injection. Try anti-inflammatories or nitrous oxide to enhance anesthesia on patients who are really hard to get numb or in areas of infection. Studies show that these drugs can help local anesthetics in areas of infection. And finally, think about alternative techniques, things like Stabident, X-Tip, and remembering that articaine does have an ability to be more effective via mandibular infiltration and possibly even by blocks, but that hasn't been shown yet scientifically.